application for partnership in asthma care. I'm going to talk about the measurement, and Dr. Friedman will speak about control factors contributing to asthma severity, and I'll speak about pharmacology, and Dr. Friedman will, we're sort of like the frick and frack, the car talk brothers here, going back and forth. Okay, measures and assessment of asthma monitoring. The clinician needs to determine that episodic symptoms of airflow obstruction are present. Airflow obstruction is at least partially reversible, and alternative diagnoses, as I mentioned, have to be excluded. Some of the challenges in making the diagnosis, we ask questions that related to repeated coughing, wheezing, chest tightness, repeated diagnoses of airway disease, allergic bronchitis, or wheezy bronchitis. Symptoms are often worsened by viral infection, smoke, air pollution, allergens, exercise, cold weather. Symptoms can worsen at night very frequently. Reversible airflow limitation. Wheezing may or may not be present in patients with asthma. In fact, I saw a patient today in follow-up, a young man who lives in Boca Raton, who had come to me because of a cough that was occurring at night. He was seen in the office. He had a completely normal examination. Really was not clear where the cough was coming from. I did a pulmonary function test on him, and this was completely normal. He came back today full of wheezes, coughing. He had classic airflow obstruction on spirometry and reversed with bronchodilators. So asthma can present differently at different points in time. Okay, so the goals of therapy are to prevent symptoms such as coughing, breathlessness whenever it occurs, to maintain nearly normal pulmonary function test, and maintain normal activity levels, including exercise and a full participation in the activities of daily living at whatever age the patient is. Other goals of therapy, to prevent recurrent exacerbations, minimize the need for emergency visits or hospitalizations, provide optimal pharmacotherapy with no or minimal side effects, and meet the expectations of families and patients as far as what they want for themselves with their asthma care. So we need to assess, periodically assess the status of the patient's asthma, to look for signs and symptoms, to check the pulmonary functions, to assess the quality of life and their functional status with questionnaires or interviewing the patient in the office, to reevaluate pharmacotherapy as it evolves, and to establish two-way communication so the patient knows what to do when there is a question about how to handle his or her disease. Peak flow meters are a very important element in home control, home monitoring of asthma. This is a poor man's pulmonary function machine. This assesses the airflow. When a patient gives a forced expiratory flow through this, it measures this, and it gives a good indication of the status of the patient's asthma. By monitoring the peak flow, the patient can assess how bad the asthma is. You can see changes in peak flow before an exacerbation occurs, and it may lead to interventions that might prevent severe exacerbations, hospitalizations, etc. However, it's not always reflective. Patient effort and patient ability to perform this test is sometimes a problem. A written asthma action plan is recommended to list the daily medications, the as-needed medications for rescue or reversal of acute symptoms, and phone numbers of who to call, who to contact in case of problems. This is where Dr. Friedman takes over.